Hello everyone, this is Dr. Hashem Abu Serhan. I'm presenting today a very unique, interesting lecture about debunking 10 myths in ophthalmology. We're going to unmask false beliefs about 10 usual facts in ophthalmology. So be tuned and focus with us. I don't have any disclosures to declare. In the beginning, I want to say that many of certain beliefs have taken root more through tradition and repetition than through rigorous scientific evidence. Dr. Todd Margolis and Dr. Anat Galor, they published a very interesting editorial in the American Academy of Ophthalmology last year, 2023. And they debunked myths related to the anterior segment. Their work motivated our critical thinking, and we bring more myths and more false beliefs in this lecture to continue to shape the everyday clinical decision. So let's start. The first myth is about mannitol. Mannitol is ineffective in vitrectomized eye. There is classic teaching that mannitol works by vitreous shrinkage, so it will be ineffective in reducing the IOP in vitrectomized or silicone oil-filled eyes. This is the classic teaching and what usually be taught by doctors or physicians. But in the reality, our meta-analysis of 5 studies, including about 360 eyes, 145 vitrectomized and 91 non-vitrectomized eyes, revealed significant IOP reductions in both vitrectomized and non-vitrectomized eyes across multiple time points. And in the vitrectomized eye, IOP was decreased by 19% at 30 minutes and about 17% at 60 minutes and about 25% 90 minutes and about 27 2 hours and about 31 3 hours and 30% at 4 hours. So mannitol is effective in vitrectomized eyes. And this is our meta-analysis, systematic review and meta-analysis published last year in the American Journal of Ophthalmology. You can go out and read it. Mannitol doesn't reduce only the IOP by vitreous shrinkage. There are other reported mechanisms by central mechanism, osmoreceptors in the hypothalamus. When they are stimulated by mannitol, they contribute to decrease the aqueous humor production. So we have central mechanism that leads to decreased aqueous humor production. In addition to that, we have the vitreous shrinkage by decreasing the by drawing the blood from the vitreous cavity. And this was confirmed by Dr. Serhan and his colleagues when they evaluated different ocular parameters after administration of mannitol and vitrectomized and non-vitrectomized eyes, and they found that axial length and vitreous chamber depth, they decreased significantly in both groups, even in the vitrectomized eyes. However, regarding the anterior chamber depth, it was decreased in the vitrectomized eyes and increased in non-vitrectomized eyes, but this change was not statistically significant. And they conclude that both direct osmotic and central mechanism, they play a role in the IOP reduction after mannitol administration. Now, the second false belief that cyclopentolate is a must for pediatric cycloplegic refraction. This is the classic teaching that when you do cycloplegic refraction in the pediatric population, you should use the cyclopentolate. The cyclopentolate is the gold standard for evaluating the refractive errors in the pediatric population. However, tropicamide is a weak cycloplegic agent and it's not recommended for the pediatric cycloplegic refraction. This is what we taught and this is the classic teaching. However, the reality, our randomized clinical trial involving 185 eyes from 94 children aged from 3 to 16 years, we compared in this randomized clinical trial the efficacy of cyclopentolate 1% and tropicamide 1% in the pediatric population with brown iridis, and we found that the difference of the spherical equivalent between the two agents was only 0.1 or 0.11, which is not clinically significant. However, the result was statistically significant, and this is clinically insignificant. And the clinical significance level at least should be more than half diopter, more than 0.5 diopter. And this is the paper that was published, the randomized clinical trial, our paper also last year in October 2023 in the American Journal of Ophthalmology. And our findings were confirmed by Dr. Yazadani meta-analysis, where they included 6 studies, 3 RCTs, and 3 case control. And the pooled standardized difference in the main changes in the refractive error between the cycloventilate and the tropicamide was only 0.175, which is not clinically significant. The third myth is that aspirin must be stopped before cataract surgery. This is a classic teaching that you should stop the aspirin at least 3 days to 5 days. Some people they stop 7 days before the cataract surgery because there is claimed risk of bleeding events either intraoperatively or postoperatively. However, in reality, our also meta-analysis of around 65,000 patients found that aspirin continuation only increased the risk of subconjunctival hemorrhage, double the risk. However, there was no significant increased risk in the sight-threatening bleeding complications like hyphema or retrobulbar hemorrhage or vitreous hemorrhage. Meanwhile, the thrombotic risk of stopping aspirin are real, particularly for patients with cardiovascular conditions. And this is our study published also last year, November, just 2 months back, November 2024, in Seminars in Ophthalmology. And not only that, the UK Cataract National Dataset, they confirmed our findings and they did analysis of around 48,000 surgeries from the UK Cataract National Dataset, and they found that in patients taking aspirin, there was no increased risk in the hemorrhagic or anesthetic complications. And the American Academy of Ophthalmology preferred practice patterns they said that evidence-based guidelines recommend continuation of anticoagulants and antiplatelet medications in patients undergoing cataract surgery. The fourth myth that prostaglandin analogues increase the risk of cystoid macular edema. This is the classic teaching that prostaglandin analogues might predispose patients with glaucoma to develop acute CME. And around in the UK, around 20% of ophthalmologists, they stop routinely prostaglandin analogues for cataract surgery. And 20% more of ophthalmologists, so around 40% of ophthalmologists, they stop prostaglandin analogues if there is any risk factors for developing CME for patients undergoing cataract surgery. Furthermore, around 80% of ophthalmologists in Greece, they discontinue prostaglandin analogues just before the cataract surgery to prevent it because they believe that prostaglandin analogues increase the risk of CME. However, in the reality that there was a large database study of around 40,000 patients in newly prescribed glaucoma medications compare the incidence of CME among the users of prostaglandin analogues, beta blockers, alpha agonists like brimonidine, and carbonic anhydrase inhibitors. And the results, interestingly, show that the incidence of CME was the lowest among prostaglandin analogues, around 0.1%, compared to the beta blockers, alpha agonists, and carbonic anhydrase, which had the highest risk of CME of around 1.7%. And this is the study which talk about the incidence of acute CME after standard prostaglandin analogues compared with other classes of glaucoma medication just published in Ophthalmology Glaucoma. And also another meta-analysis, Dr. Oziol meta-analysis, they confirmed the findings and they evaluated whether using prostaglandin analogues perioperatively is associated with increased risk of the development of clinical or subclinical CME after uneventful cataract surgery, and they showed that the incidence of CME after uneventful cataract surgery was similar in patients who continued or discontinued using prostaglandin analogues. Similarly, the fifth myth is that about prostaglandins analogues increase the risk of uveitis, which is the classic teaching that prostaglandin analogues disrupt the blood aqueous barrier, increase the risk of uveitis, so you should avoid use prostaglandin analogues in the uveitic glaucoma. However, in reality, a large database study of around 67,000 patients, glaucoma patients, in newly started topical anti-glaucoma medications, they evaluated the incidence of uveitis among the users of prostaglandin analogues, beta blockers, alpha agonists, and carbonic anhydrase inhibitors, and also they showed that the incidence of uveitis was the lowest among prostaglandin analogues users compared to the other agents, around 0.3%, and the highest was for beta blockers of around 1.9% increased risk of uveitis. And this is the study, incidence of uveitis following the initiation of prostaglandin analogues versus other glaucoma medications, published also in Ophthalmology Glaucoma just recently, November 2024. And also Dr. Chang multicenter study, they have also the very similar conclusion where they analyzed 163 eyes of 84 patients with uveitis and raised IUP that treated with prostaglandin analog, and they found that significant IUP reduction were observed during prostaglandin analog treatment, and there was no significant difference in the frequency of anterior uveitis in those eyes treated with prostaglandin analogues and those treated with non-prostaglandin analogues. And there was no increased risk in the frequency of CME during prostaglandin treatment compared with during non-prostaglandin treatment. So it was the same, very similar. Coming to the very common false belief, number 6, that strict face down positioning is a must after macular hole repair surgery for anatomical success. This is a classic teaching that strict face down positioning is a must after macular hole repair surgery for anatomical success to increase the success of the surgery. And around more than 90% of vitreoretinal surgeons worldwide recommend some period of face down positioning after macular hole repair surgery with different durations. Some of them reported 3 days, some of them 5 days, some of them 7, 10, and until 14 days. However, in reality, a Cochrane Library database review of 8 RCTs involving around 700 eyes found no significant difference in the macular hole closure rates between patients who maintained face down positioning and those who didn't. And this is the study face down positioning or posturing after macular hole surgery in Cochrane Library, and it was published in 2023 November. Similarly, Dr. Basso multicenter RCT study, they concluded similar findings where they evaluated the value of face down positioning following surgery for large full thickness macular holes. Even if in large full thickness macular hole repair surgery, their results don't prove that face down positioning post-operatively is more likely to close large macular holes compared with facing forward. Coming to myth number 7, that superior laser peripheral iridotomy prevents dysphotopsia. And this is the classic teaching that when you do laser peripheral iridotomy for any patient with primary angle closure or primary angle closure suspect or primary angle closure glaucoma, you should do it at the superior quadrants between 10 and 2 o'clock in order to prevent post-laser dysphotopsia. And they believe that hiding the iridotomy behind the upper eyelid would reduce the visual symptoms. However, in reality, systematic review of around 1,700 eyes from 78 patients compared the incidence of dysphotopsia based on the laser peripheral iridotomy location, superior or inferior nasal temporal, and the analysis found no significant difference in the incidence of dysphotopsia among the location groups. And in overall, the incidence of dysphotopsia was about 2 to 3% regardless of the laser PI location. And interestingly, they found that laser PI could resolve pre-exiting halos and glare, suggesting that laser PI may have some beneficial effect on visual symptoms. They hypothesized that with patient primary angle closure with attacks, they develop corneal haze that can result in glare and halos and dysphotopsia. And when you do laser PI and you resolve the attack, you clear the cornea, so the pre-laser dysphotopsia resolved. And this is the study in the Royal College of Ophthalmology journal, the Eye Journal, which is very popular. Dysphotopsia and location of laser reductive systematic review. And if you see here in the new linear dysphotopsia, the percent of this dysphotopsia was around 2.8% in the superior location, was highest in the superior location, and 2.7 in the inferior, and around 2 in the nasal and temporal quadrants. And not only that, another multicenter RCT, they also have this very similar findings where they included around 559 patients diagnosed with primary angular closure suspect, primary angular closure, and primary angular closure glaucoma in both eyes, and they concluded that neither laser PI location, nor the area, nor the total laser injury predicted higher odds of new postoperative dysphotopsia. The false belief number 8 that baby shampoo should be first-line treatment for blepharitis, and this is very classic teaching that you use lid scrubs with baby shampoo to treat blepharitis. However, in reality, a Cochrane Library database analysis of around 34 studies with 2,000 participants with blepharitis, they concluded that there is no strong evidence exists for any treatment for chronic blepharitis. And even that commercial products are marketed to consumers and prescribed to patients without substantial evidence of effectiveness. And when we asked Johnson & Johnson Consumer Care Baby about the use of baby shampoo for around the eye periocularly, they replied, we don't advise using the product in the eye area. And very interestingly, in 2004, the American journal Contact Dermatitis named the cocamidopropylbetaine, which is the primary ingredient, the primary constituent in the Johnson & Johnson baby shampoo, as the contact allergen of the year. And this is the study interventions for chronic blepharitis published in the Cochrane Library database, which is very, very strong library analysis. And also the College of Optometrists in the UK Clinical Management Guidelines, they said that there was insufficient evidence to make any recommendation based on the relative effectiveness of different methods of lid hygiene. This is one of the very popular case reports published in JAMA Ophthalmology about the development of chronic eyelid dermatitis secondary to the cocamidopropylbetaine allergy in a patient using baby shampoo oil scrubs, and you can read it from in this journal, JAMA Ophthalmology. Myth number 9: non-preservative artificial tears should prescribed. Preservative-free artificial tears should be prescribed if patients use them frequently. This is the classic teaching. The prescribing pattern: if you are prescribing artificial tears more than 4 times daily, you should prescribe preservative-free artificial tears, preservative-free lubricants drops. However, this is cost burden because preservative-free drops is much costly than the preservative usual lubricant drops. And the reality, one of the systematic review and meta-analysis of around 323 patients, they found no statistically significant difference between the two groups, between the patient who received preservative-free drops and the patient received preservative drops, and there was no side effects statistical difference between the two interventions. They concluded that evidence proving that preservative-free artificial tears are more effective or safer than preserved artificial tears is lacking. And this is the study, you can go and read it, about the effectiveness of using preservative-free artificial tears versus preserved lubricants for the treatment of dry eye, systematic review and meta-analysis. Last but not least, the myth number 10, that topical corticosteroid drops need to be tapered when you prescribe them. This is a classic teaching, tapering topical steroids always to avoid rebound inflammation, and you should win the eye of its drug dependence. And the reality, the concept root of this classic teaching, that abrupt cessation systemic steroids might lead to rebound adrenal suppression which is known as Addison disease. However, there is no data that support that this claim that as soon as you start the topical steroid drops, the eye becomes steroid dependent, and so you need to taper the steroids in order to prevent rebound inflammation. And about the inflammation, we have two patterns: scheduled reduction and supervised reduction. The scheduled reduction, that when the surgeon knows the natural course of this inflammation. The best example is postoperative cataract surgery inflammation. So you know that the first 1 to 3 days is the highest inflammation, and with time it will resolve by time. However, the supervised reduction, like uveitis specialists, when they do treat uveitis attack and they will see the response of the patient eye to the steroids, then they will reduce, then they will see how it's now the response of the eye, then they will reduce, trying to reach the least effective dose of the steroids that provide you the best target effect. And there is nothing about these two steroid reduction patterns related to rebound inflammation, because rebound means that there is something pathological process. And supporting that there is a new guidelines which published in National England Journal of Medicine, which is the journal number 1, about glucocorticoid induced insufficiency guidelines from the European Society of Endocrinology and Endocrine Society, and they say that tapering is not necessarily unnecessary when treatment duration has been less than 4 weeks, regardless of the dose. However, when you do systemic steroid therapy more than 4 weeks, the dose should be tapered to minimize the steroid withdrawal symptoms and to prevent hypothalamic pituitary axis shutdown. This is about the systemic. Even in systemic steroid therapy, you don't need to taper steroids if you are using them less than 4 weeks. What about the topical drops? If you are using topical drops, no need for tapering even less than 4 weeks by this guideline recommendation. And this is what we say about finding the least effective dose, that we have scheduled reduction. The natural course of the inflammation, for example, postoperative inflammation, it will be maximum at the first day, and with time, it will resolve with time by itself. So no need to taper steroid to prevent rebound inflammation, because there is no rebound inflammation. This is the course of the inflammation. If inflammation happens after stopping the steroids, means that this patient needs steroids for longer period, for example for 5 weeks, 6 weeks, to stop totally the inflammation. However, in the supervised reduction, for example, patient with uveitis attack, you will give him, for example, in the beginning every 1 hour or every 2 hours, then you will reduce it to see the response, then you will reduce it for 4 times, then 3 times, to find the least effective dose that causes this patient to be stabilized, and with the least dose, so you prevent complication like posterior subcapsular cataract or glaucoma or other complications. So the take-home message from this lecture: give mannitol in vitrectomized or silicone oil-filled eyes. Use tropicamide for cycloplegic pediatric refraction. Don't stop aspirin before routine cataract surgery. Prostaglandin analogs don't increase the risk of CME or uveitis. You can give them in uveitic glaucoma. Face down positioning is not mandatory or a must after macular hole repair surgery. Do laser peripheral iridotomy wherever it's feasible. Don't prescribe baby shampoo for lid nephritis. It can sometimes lead to allergy. Lubricants with a preservative can be given for a longer time if needed. And tapering topical steroids is not a must. This is the last message from me, and thank you all, and hopefully we'll see you again later soon, inshallah.